Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa, and today I am joined by another nurse, Elizabeth Anderson. Thank you for being with me today.
Rosa, thanks for having me and thanks for creating this platform for nurses to use their voice. It's really inspiring listening to you and listening to the guests you bring on your podcast.
Yeah, definitely. And I do love a good interdisciplinary team. That's was my favorite thing that I learned from my bachelor's program was about the importance of the interdisciplinary team. And so I love bringing in people with all kinds of different perspectives because as humans, we are all healthcare stakeholders. But as nurses, I think we do have an insight that a lot of other people don't have. So could you share with us your story, your history in nursing, and where you're working now?
Absolutely. I'm a very proud nurse of 15 years. I spent time at bedside in the critical care space, had great opportunities to engage in different committees, from the alarm committees to the magnet chairs and governance, things like that. I also, while I was at bedside, because most nurses have more than one role, I was an educator for college in the local Chicagoland area and really enjoyed connecting with students in helping them understand nursing is so much more than that global perception of either passing a medication or the critical thinking decision making and where our careers can take us beyond bedside. Bedside's a great place to be, and we need those strong nurses to stay there, but we also need those strong nurses to explore other opportunities to impact healthcare, from technology policy across the board. So time at bedside, was a nurse educator as well. And then I stepped into corporate on the med device side and have really opened my eyes into the practices of designing solutions for the healthcare space. So while I was at bedside and while I was teaching it as well, the technology that came into the patient care space often felt forced and often felt it was out without the voices of nursing practice, nursing science. We were kind of given these tools, if we can call them that at the time. We're given these tools instead of being an active partner in the development and the adoption of those tools. So my focus where I work now in the med device world is really making sure we're centering nursing voices from ideation to implementation throughout before a line of code is written, that we are making sure it's not a token task to have a nurse on board, but we're really integrating nurses not as end users, but as co-creators for our medical technology that's going in those patient care spaces.
And is that a priority that was present when you signed on, or is that something that you feel like you've had to emphasize as far as not being a token nurse on board? Which, hey, we got to start somewhere.
We have to start somewhere.
Having a
Yes.
nurse-centric design means that we'll have less workarounds on the end user side,
Yes.
and we can actually maybe keep these devices or whatever innovations once they're implemented. So, do you feel like you had to really teach your industry side job about that perspective, or did they already have that when you joined?
I think it's 50-50,
Mhm.
right? I've worked with teams who have been in the med device field for many years, who were accustomed to approaching medical technology as a construction job, or biomed and clinical engineering were the only voices that were at the table to vet those technologies coming in. And we know healthcare has changed. It's not necessarily those teams who are making the decision. It's moved into your CIO, your CNIO, your CNO are not being brought in after the decision is made. They have a seat at the table and they have a voice at the table as well. So there's a lot of context that needs to be provided to teams who don't work within the hospital on a day to day and don't have that context or touch point. So where some teams were ready to say, Elizabeth, tell us what's happening out in the market. We want to learn, we want to know, we want to expand our offering and our solution to fit the needs of the teams that are providing patient care out in the field. We also have teams, as we see everywhere with every industry, of um, that idea, we've been successful creating this product for many years. We've been doing a good job, and we're going to keep going down the same path we've been on for years, and getting those teams to understand just just needs a little bit more coaxing, massaging, and evidence, data. I'm all about the data. So providing that data. And I think where that data is the nursing voices, making sure that the teams who need more information are getting that information, not just from me as a nurse and as an expert in the field, but from end users who are currently engaged in direct bedside care as well. I'm always happy when I can change those minds and they can get on board with the significance of what is happening for nurses at bedside, right? We're not just passing a medication and walking out of a room. The intricacy of what is happening, that when we're introducing that technology, we can't just say, here's a technology, put it into a room. How else is it interfacing with the ecosystem inside that room, in the hallway, in the nurse's station, and so on?
Mhm.
So there's a process sometimes, but I think most people are open when you're providing the data and then providing the context with the real world voices of those nurses really helps teams get on board.
Yeah, definitely. And what are some of the technologies that you have seen nurses be integral to developing?
Gosh, I'd say can we say everything? Every technology that has a nurse behind it has been good?
Well, do you have like a favorite where you're like, see how great this is?
Yes. So I think when we even look at the design and the workflow aspect and the
Oh,
integration piece, so we know our health systems have had a lot of disparate technologies, haven't been talking to each other. That integration and interoperability has been an uphill climb for the healthcare space for a while. And when we have, I would say it's not a specific product. But when we have vendors talking to each other and working with each other on the vendor side to say, we know nurses need X, right? We know they need seamless communication. We know they need easier collaboration from cross functional engagement. We know they need more data. More easily accessible from a single platform. When we have the vendors working together and we're seeing the integrations and the open APIs that are coming forward, when the hospitals are selecting their technology and they're showing nurses and talking to nurses about what's possible. It's not this phone will ring, this light will show in the hallway. This they're talking about the whole experience that nurse will benefit from. And I think that ups the adoption because that's the first step. I know I'm going on a tangent here, but that's the first step. If we can't get the nurses excited about the technology to even have them use it at bedside because we're so used to workarounds at bedside, that's that first step. And I really think it belongs in that vendor to vendor success and then vendor to hospital success pipeline as well.
yeah. Do you want to share a story of when you saw technology be not adopted right away?
Gosh, could we have 2, 3 hours to talk about all of our shared experiences
Right.
with that? So, technology not being adopted. I'll say a common theme, unfortunately, in some hospital spaces is when technology is being brought into bedside for our nursing teams, we forget the aspect of the design process and how much we need the nurse's voice to understand the movement that happens at bedside. We know it's not the same between beds. We know it's not the same between units. So hospitals will say, I brought this nurse call solution in close to my heart, a system I work
Mhm.
with right now. Brought this nurse call solution in. We're going to give the staff this, and everyone, every unit, every bed is going to work the same. And it immediately, not within months, not within days, but within hours, it's evident that it is not working for staff and they are no longer engaging with the system. They did not, the hospital system chose to not engage with staff to understand workflow design, to know what would ease the workflows for the staff, what would ease communication, what would ease collaboration in that space. So nurses automatically turn to the workarounds. They're leaving the room to go get the resources, their physical resources, people resources that they need. Back to pulling out that piece of paper in our pocket that has our phone numbers on it, that has our medication list that's there. That is all valuable time the nurses don't have. What's even more valuable, no, that's a lie. It's not more valuable. What's equally as valuable is now the time it takes to redesign the system. So you've lost the resource of trust that you have with staff, right? You've put a system in, it didn't work for them on that first attempt, and they designed a workaround. And now they're hesitant to want to engage again. You've lost the resources maybe for IT, biomed, clinical engineering that needs to go into the system design or configuration as well. So that's time, that's money that the hospital doesn't have to use. So I can say from physiological monitors to nurse call systems to IV pumps across my nursing experience, how many times when nurses weren't involved in the design process from the hospital side failed, I'm serious, within hours, and
What
staff
did
were immediately shifting to workarounds.
and what did that look like?
Oh my gosh. I mean, talk about the frustration when you get excited that something's going to work for you, right? You're excited that you have a tool that has been promised now to make something easier or save you time. And instead, I'm, as a nurse, frustrated at bedside, right? What frustration, burnout, cognitive overload, all of those pieces that are there.
From whatever this technology is you're supposed to be
Whatever.
wearing, like, alarming too frequently.
Absolutely. So it's alerting too often. It's alerting people who cannot address the alerts as well, or you're receiving alerts that aren't necessarily clinically in your scope of practice that's now adding burden
Mm,
onto you, plus the alarm fatigue that's there.
mm.
So there's time, which is the most valuable currency we have as nurses when we're in our shift, eliminating the time that we have for that direct care because we're hunting and gathering those resources. I am frustrated because what has been promised to me that is supposed to help me at bedside isn't helping me, and I have to immediately find a workaround. I'm frustrated because maybe my phone is ringing more, either in my pocket or at the nurse's station. There's an alarm. Where is it coming from? What room is it coming from? All those pieces that are there, the cognitive burden. And now it's the end of my shift and I am frustrated.
How often do those tools just end up shoved in a drawer and hidden because they were more problem than they
I
were sol
I think we've both experienced that. We've both seen it. Intercom badges. I think we've talked about this before. Badges that enunciate that are sending everyone every alert for every room on the unit and how fast those go into a drawer. Doing walkthroughs, getting to the Gemba to understand what is your current state and going over to those filing cabinets. And they're saying, here's my RTLS badge, here's my, intercom badge that's there. We don't even use those phones anymore because they just ring all the time, or the phone was in my pocket and I put it on silent. So it might as well just stay in the drawer that's there. And I mean, at that point, when you're providing care, you're just chasing your tail. You're chasing the lights. You're trying to stay on top of your tasks, and you're relying on people who are doing the same behaviors that you are,
Yeah.
right? Yeah. I design from the solution itself, but also design when we're talking about bringing the solution into the hospital. And I think that's something all hospitals should do. Easier said than done. Piloting is so important. Making sure we're getting a pilot either in an innovation lab or on a pilot unit within the hospital will help decrease a lot of that fatigue burden or investment that's now going into a filing cabinet drawer
Mm,
that's there.
yeah. Yeah, I've seen some really great pilot programs, and usually, um, if they're going well, then it's like, how soon can we get this rolled out to the whole rest of the hospital? Because it's really
Yes,
helping their workflow, right? Like different virtual nursing options that
absolutely.
fill in a lot of like educational gaps and things like that.
And have
So,
you then seen when the pilot unit is enjoying the pilot of solution, somehow the nurses on other units are hearing about this saying, I want it on my unit as well?
mhm.
That good news traveling fast throughout the health system.
And then they'll be excited when it's their turn to learn how to use it because they believe it's going to work instead of just what's the next thing that I have to learn how to work around? Because I think you and I were talking the other day about how nurses can be considered resistant to change, but how much of that is due to the fact that we were not consulted about what changes needed to be made and how.
Absolutely.
Then we're given a new thing to do that requires training. And if you have so many bad experiences with a new process that you're taught that just makes your life harder, then it gives you that negative feeling that the next thing is just going to be more work because I'll, one, have to learn how I'm supposed to use it. Then I'll have to figure out how to work around it to do my actual job, but still also not get in trouble for not doing the original process because we don't even believe that's going to work.
Yes, yes, and then not the resistance to change. We're hesitant for change that didn't include our opinion. And again, that pilot is a great way to spread the word through the nursing team to say
Mm.
nurses have already validated that. And then moving through that hesitancy or removing that hesitancy because they're aware of the real world implications that are there, I think is wonderful. That we can do that, and I love for that narrative to change about nurses, for people to understand you can't keep shoving products or solutions that don't work for their care space and then saying they're resistant to change. They're not resistant to change. They're hesitant for now the time that they've pulled back to themselves because they've developed workarounds for solution A that didn't work. Now you're giving them solution B, and to all the points you just made, Rosa, okay, I'm going to have to do X, Y, and Z, and then no one's going to provide data on the output either to say if it's working or not. That's another flaw that we have of the follow up through the data to show are
Right?
we even efficient with the technology that came through.
Yeah, because you and I were talking about this call light idea that can have different buttons for different needs, right? Like one is for or something wants to get up and go to the bathroom. What were the others?
Yeah, so from a pillow speaker, having a generic patient button, that's what we're used to. But
Uh-huh.
then having the context of pain, water, toilet, where those are traditionally the highest call needs of the patients when they're on any given unit. And understanding that each discrete call can be escalated and routed to a specific care member. So a pain call can route first to a nurse because they can address a pain need, or a pain call can first route to a virtual nurse so they can do the assessment to understand, does this necessitate pain medication? Is this more a positioning? What's occurring with the patient to provide that further
Mhm.
context as the direct on site care team is still caring for another patient. And then they can gather the materials that they need to go in. Allowing that water call to go to a nurse assistant, a PCT that's there. Is the generic patient call, does that go straight to the unit secretary who can help triage to understand the needs that are there? And then every time the system is engaged with that pillow speaker, that touch, we're generating data. So on
Mhm.
an ortho unit, those pain calls, how often are we receiving pain calls from a TKA, right? A knee to an ankle to a shoulder to a wrist. What does that look like for different providers when we start pulling in ADT information? Dr. Smith's patients come out of surgery and within 30 minutes, they're requesting pain medication, and Dr. Jones about 75 minutes after for the same procedure. We know doctors have different order sets that are in there and trying to follow and keep up with them. How do we provide the context from those touch points, the data, to nurses to get in the anticipatory state instead of the reactionary state that we're all always, when I say chasing our tail, chasing our call lights that are there? How do
Right.
we pull something we don't typically think of? Nurse call system, patient pressing that button, providing us more context, tying that into our ADT feed, tying that into the physiological monitoring as well to give us predictive insights into what's occurring with the patient. Just a different way to think about the patient care space.
And as an experienced nurse with, like you said, different doctors who have different ways of approaching things, you get to know what to expect and you know to ask because their order set doesn't include a
Mhm.
certain PRN medication, but you know that they're fine with ordering it because you've called them 5 times for it already or 50 as the case may be. And so you know that when that patient gets wheeled up, you're already calling requesting that order.
Mhm.
Hey, if they have pain in an hour, is it okay to give them this? Can I have that order now? But like you said, having someone who's knowledgeable and prioritizing using that data in a predictive way,
Mhm.
looking at this systemically with not just one nurse and one doctor, but over an entire system, right?
Mhm.
So, like, if you work in a hospital system that has multiple hospitals and thousands of patients, and your turnover has resulted in the staff being made up of nurses who have less than 3 years of experience,
Oh
they
yeah.
may not have been taught to interact with providers in a prophylactic way,
That's a
preventing
great point.
emergencies, right? Like, who knows how they're being educated? Are they being educated to have open lines of communications with their providers? Are they being taught to anticipate things like that ahead of time? Or is it more of that just reaction chasing their tail because they haven't been instructed right? So we need these experienced nurses to be applying
Mhm,
strategies like you're verbalizing that you and I might have practiced ourselves individually,
mhm.
but extrapolate that in a way that can help all these nurses who may not be at the bedside more than 3 years and
Right.
pass
And
on that.
getting, being on the vendor side to say, "Hey, engineers, hey, product managers, I need you to think this way. I need you to see the whole ecosystem of that patient care as well." We've talked about this. Do people really understand what is happening at bedside and the care
No,
that's there, right? Time, motion,
no.
right?
Unless they watch The Pit, then they might have an
Yeah.
idea.
Oh gosh, what a great show. That's Can we do a whole episode on that? Like, what a great representation of what actually happens at bedside. When I've
Right.
had friends say, "Is that really what it's like?" Okay, great. We're starting to see a little bit that's there.
Yeah.
Time motion studies focus on how do we financially, reduce labor costs of steps of how fast you give a medication. That's not talking about what's actually happening at bedside to help us build solutions to make it a better experience for our nurses so we don't have full units or full hospitals of nurses with under 5 years of experience. That we're retaining staff because we're not adding more friction to their day. We're actually allowing them to practice the science of nursing to provide direct patient care, spend more time there versus managing. I call it, there's patient care management and there's technology management, right? Putting tickets in for things, something's not working, something's broken. I don't have time to deal with that, but I have to find time now to deal
Oh,
with that.
girl, I just learned how to use AI for a new thing, and this is super basic, but I use Google Calendars because you and I have had to
Mhm,
reschedule
mhm,
some things over
mhm.
a few times.
Yep, yep.
But I just linked up Gemini to my Google Calendar, and I can tell it to remind me to do this at such and such time, and it
Oh, that's
adds it
great.
to my calendar. Game
Imagine.
changer. What if you could just talk to your device and say, "I need a ticket to travel for this patient to go down to MRI," and there you go.
Absolutely. Absolutely. What if that MRI order goes in and because all the scheduling in the background, we have to wait for the MRI to be ready. When MRI is notified that or makes us aware that it's ready for that patient to come down, we are passively receiving that information to a phone, to a badge, whatever that looks like. And then we're speaking back to either say, be ready in 15 minutes for transport, and that goes off to transport. How are we reducing those steps even more where I don't have
Mhm.
to engage with the systems as much, that the information is freely flowing to me
Yes.
because of what the how the technology is set up to integrate with each other.
Yeah.
I'm on board with you. Let's do this.
Mm. I love that. I love the talking and interacting. I know that can be an issue with different accents or whatever,
Mm,
and I know, like, with Dragon, the docs have to train it to their voice and everything.
mhm.
I was just talking to one of my favorite physicians about using ambient AI for her note taking, and she said she thinks she would have a really hard time training it. And I said, "Is that because you code switch all the time?" Because she's like mirroring people's different speech patterns.
Oh,
She's
that's
like the
interesting.
most emotionally intelligent people I've ever met, and she's so good at connecting with people. I don't know if AI voice could keep up with her specifically, but so I think it might have been a little more time consuming if she needs to train it. But I do love the idea of being able to speak to
Mhm.
our technology to activate it. And girl, we could be living in like the Star Trek Enterprise world where you're just like computer, this, that, and the other. And
Yes.
just
We
like you
just need
order
it
your
to chart
groceries.
for us. We need it to
Yeah,
not a note. I'm all about a note. Not a note. Make it into the cell in the flow sheet.
exactly. Cause that's what I was talking to my bedside friends the other day about is the ambient charting that's designed for physicians to write their notes is
Mhm.
not designed to fill in all these essentially spreadsheets is what nurse charts look like because we got to fill in
Yes.
all these blanks. And if it's a stroke patient and they have a neuro assessment in addition to an NIH stroke scale, all of those little boxes have to be filled in.
Mhm.
And a lot of the time, you can do a pretty quiet assessment that's thorough on someone and without verbalizing anything. And if you're trying to like not wake up somebody who's sleeping next to the patient in the room when you're doing their assessment,
Mhm.
I mean, adding in having to verbalize a whole lot of things could really make everything take longer. So I think maybe like emotion tracking, kind of like you were talking about
Mhm.
tracking, could be more helpful for nurses in the room to kind of see what's happening and who's in there and like what's being done in there in general, right?
Mhm.
Not quite anonymized because we have cameras in patient rooms anyway for safety to
Right.
help with tracking against falls. But like if you have to have 6 human people in there to lift a patient every 2 hours because they're 600 pounds,
Mhm.
I would love to have that recorded for data
Sure,
because
and
that is not accounted for.
not and I think you agree, we've talked about this, not data to say nurses work faster. You should be able to
No.
turn a patient in 4 minutes. You should be able to calculate and hang chemo in 7 minutes, I mean, anything like that. For people to understand what
Mhm.
is happening at bedside, what patient care really looks like,
Yeah.
where we can't say, a ventilated patient requires X, Y, and Z. Yes, care bundles and evidence-based research is out there to say certain care aspects, that's just a piece of what's
Yeah.
actually happening when we're at bedside.
Yeah.
So as you're saying, capturing all that movement, capturing the people as well, um, I think is significant. It would be a great innovation for us to have uh, as nurses for I hate to say like the rest of the care teams, but the care teams, the hospital systems, medical technology innovators to understand what nurses do on a
Yeah.
shift by shift, hour by hour basis.
Like when they
That
talk
just
about
again,
workflow,
unless you
like it's
watch the pit.
yeah, then you have an idea. Like the workflow doesn't look like an organized algorithm. Okay. So every time I hear people say the word workflow, it irks me because they're thinking of some kind of if this, then that algorithm workflow.
Sure.
And that is not how nursing works. That is not how interacting with patient works. Like it doesn't account for all the interruptions. Like imagine at least one interruption for every step of that workflow that builds an
Absolutely.
additional tree that you have to triage in your mind between two
Yep.
to five different patients in a hospital or
Patient arrives to a unit, the admission process. I
yes,
don't think I ever had the same one twice. I don't think I ever had one that wasn't interrupted.
right? Exactly. Like, hallelujah for virtual nurses that can help with
Yes.
admissions and
Yes.
discharges.
And now we need to make sure we're closing that gap of virtual nursing and direct patient care, that they're very aware of the tasks that the other caregiver is doing. So there's not redundancy
Mm,
either in task,
yeah.
and that there's awareness, situational awareness of the process, where they are in the process, and when it's appropriate for each care team member to be engaged in that process as
Mhm,
well. But I'm happy with where virtual nursing is going
mhm,
as an asset and not a replacement of
mhm.
direct caregivers.
And as we talked about before, like, we're not currently replacing nurses fast enough. So I'm not really worried about AI taking all of our jobs because we're already not keeping those jobs by choice. So let's go to your $1 billion idea.
Okay.
Elizabeth, if you were given a grant for $1 billion, how would you like to see it used strategically to meet the needs that you see in healthcare to have the most sustainable impact?
First, I'm going to give you two. So, first is investment in comprehensive preventative health, providing basic needs from nutrition, housing, equitable access to healthcare. We spend so much time reacting to illness when we can be promoting wellness. So, again, that is a multi day discussion, but investment in that preventative health side, I don't think I know trickles down into so many different avenues within the healthcare space. And the second investment I would love to see is to the value of the nursing profession. I hope this is not a controversial thing to say, but most states, most hospitals, nursing care is included in the room cost, is included in a physical location, is not viewed as a significant clinical intervention that is impacting patient outcomes, patient safety, the patient experience. So when we don't look at nursing as a clinical intervention, and then we see costs hospitals have to be aware of. Nursing gets put in this cost containment, kind of that first swing where we start pulling resource teams back, resource payback. We start taking away overtime, all of those pieces that are there because it's tied to that cost of the room, and we don't see that discrete care that is being provided across the board. I think it's easy for hospitals to go after nursing that's there. When nurses account for the largest portion of clinicians in the healthcare workforce, right? Healthcare field that's
Yeah.
there. I don't want to say we need to make nurses billable to nickel and dime people coming in to receive care. But I think until we view nursing care, nursing intervention, the nursing profession in a way that we can code and bill the care that's being provided, we're going to continuously run into this. We don't know why nurses are leaving the profession. We know nurses are burnt out. A pizza party's not solving it. We've been talking about this throughout our conversation today of what's actually happening at bedside, what nurses are actually doing at bedside, the care that's provided. And healthcare systems are not looking, in my opinion, valuing nurses. We have a billing code, I think, for AI already, correct? That we can
Mhm.
put in, and we still don't have a code for nursing intervention and nursing care, clinical decisions, early detection of clinical deterioration, patient education, care coordination, right? This isn't putting
Mhm.
on a band aid and handing someone a pill in a cup
Mhm.
that's there. There's so much knowledge, there's so much critical thinking nurses possess to keep these patients alive and healthy every hour of the day that is not being considered.
Mhm.
And then we have health systems surprised and sometimes confused about their retention of their skilled nursing staff. That there's nurses on units or without the whole hospital, that majority have under 5 years of experience.
Some administrators who have no clinical experience have shadowed their team, and like some of the best CEOs will shadow each member of each like
Mhm,
line of clinicians.
mhm.
Spend a day with the doctor, spend a day with the nurse, and spend a day with the housekeeping and see what their workflow is like, not in an algorithm, but in real life. And really spend a day in their shoes so
Yes.
that you can understand what is currently being required of them and see if you would want to do it.
That is a statement. See if you would want to do it. See if you'd want to do it for a pizza party as a reward, right?
I was going to say for a smidgen of that administrator's salary, but you know.
Right? It there's so much around this piece when we even move away from the hospital space, the traditional where nurses have lived, and we come into the corporate space. When we look at vendors, when we look at systems that have nurses that are leading teams, that are part of teams, I think it's sometimes surprising and then sometimes not because how hospitals view lead out into how public views nursing as well. What the value is. I think you had spoken about, you said your husband, if he wasn't married to you, wouldn't know the extent of what nurses do,
Yeah.
right? That's
Yeah,
there.
exactly. He and I were talking about the brand image of nursing, and I was like trying to verbalize what it is to me and using all these grandiose terms because I love nursing and all the amazing things we can do. And he was like, "Well, not every nurse is like you." And I'm like, "Well, sure, but all nurses should be like this, that, and the other." And he's like, "But if I go into a doctor's office and I see the receptionist and the person who draws my blood and the person who weighs me," and he's like, "As far as I know, if you're wearing scrubs, you're a nurse unless you say you're a doctor." And so none of those people I encounter fit the description that you're putting in writing. And I was like, well, those aren't nurses. Those are, a receptionist, maybe a med tech, maybe a
Right.
phlebotomist. They're not nurses. They don't have that, I'm not saying they can't do critical thinking, but I'm saying they're not responsible
It's
for
a different scope of
all
license.
of yeah, they're not responsible for the same things, the same patient care,
Yeah.
comprehensiveness, intermediating with
Yeah.
providers and
And I
advocating
think in
for
the same tone, someone will say, well, I was in a hospital or my dad was in the hospital and the nurse would just come in and walk out. Or I'd see the nurse and they were just on their phone. A
was it
very
even a nurse?
one, is it even a nurse? But two, if it is a nurse, do you understand maybe they're charting on their phone?
Right?
When they came into the room, do you understand the 5 other patients that they're taking care of and how inefficient the systems they're working with are? That they only have a period of time to talk to you looking at their EHR and then walking out of the room. It's that lack of understanding of,
Yeah.
yes, the care that goes on, but also how inefficient so many of our systems are in the healthcare
Mhm.
space that require our care teams to kind of be in and out. And then also the public view is you're in a room, you're in a single room experiencing this. Multiply that out for the whole unit. Because let's be clear, you never just care for your assignment.
Mhm.
You're caring for everybody and the other staff members that are on that unit as well. So, um, yeah, investment in how we view it. Does it go to code for billing because we've actually looked into what nurses are doing and we're aware of how much work goes into a single patient stay? I think would do so much for our profession, not just in the direct patient care space, but then extend that out throughout the healthcare continuum of what nurses are capable of, what's possible, and how well our skills transition from bedside into honestly a job. Any job. I tell nurses all the time, you could do anything stepping away from bedside. And I think you should.
Yeah. Well, we are not saying that all nurses should step
Well,
away from
not all nurses, but if you
we
want to, you should. If you're
Right.
thinking about it, you should. We know that the ability to maintain and keep your license and know that we always have a need for nurses as well.
Mhm.
Try out something different from bedside if that's what you're thinking about. And then if you know your bedside is your passion, you can return to bedside and you're still bringing even more valuable skills back to bedside as well.
Yeah.
And then
Well,
if
and there
you,
are
yeah,
PRN options if you wanna
absolutely.
keep your foot in the door. There
Absolutely.
are WOW positions where you just work on the weekends and do other things
Gosh.
during the week.
Yep.
So, yeah, there is a lot of flexibility even within bedside nursing,
Yes.
and I think that's one of the things I really like about it too, but, yeah, I really wanna help, the people that I still see when I go around to the hospital optimize so that they can, stay in that situation and make it better. I want to make it a better experience because hospitalizations happen because they have to happen. Like
Right.
nobody is going into I say nobody. There are some people who just want to be hospitalized. Most of the time, people try it, they
Majority of
might
people
not
aren't
be
there for fun. Right. Right.
exactly.
Right, and how the teams that are working at bedside, right, and have passion for direct patient care to maintain that space and be in that space, how do we make it better for them, right? What are we doing across the board to make sure that this is a better experience, that they can be in control of the day, that they feel empowered when they walk onto their unit and not discouraged that they have not just patient care to do, but technology care, workaround care, knowing they're going to run up against friction from some technology that's been put in their hand. How do we prevent that from happening so we can allow those passionate bedside nurses to be empowered in their
Mhm.
patient care?
Exactly.
I'm here for
Well,
it.
yeah, me too. Well, thank you so much, Elizabeth,
Thank
for
you.
dream building with me here today and giving us a peek into behind the curtain do you count as an industry nurse? I think you said corporate earlier, but
But let's make up the term,
sure.
whichever way.
Well, whatever, it's you, so you get to pick.
Let's say a corporate nurse, a nurse's nurse. Does that work?
Yeah. So, because I think it is good to know you're not trapped in anything. There are lots of other options out there. And if you've enjoyed this episode of the Nurse Rosa's Insights podcast, please like and subscribe wherever you're listening or watching. If you're watching on YouTube, tell me in the comments if you learned something or if there's someone else with a $1 billion idea that you think could transform healthcare. And I will want to interview them as well. Elizabeth, where would you like people to find you if they would like to talk more about this?
Connect on LinkedIn. Always happy to have a chat, grab a coffee, grab a lunch. Always excited for innovation conversations.
Definitely. And I will put her LinkedIn profile in the show notes. You can find me on LinkedIn as well. I will have all my links on a link tree in the show notes. And you can follow me on social media on all the platforms at Nurse Rosa Speaks. And I will see you in the next episode.